Hello everyone. Nowadays, when it comes to cardio-metabolic health and diabetes management, you can see numerous discussions related to SGLT2 inhibitors. We can see so many scientific programs, CMEs over these topics. And also, they are the trend in current clinical practice. So today, I will discuss in depth regarding SGLT2 inhibitor and the commonest discussions which are happening in all these scientific sessions. All these details are prepared by myself 1 year ago when I presented the seminar particularly on Dapagliflozine. That time we named it as sweet to indicate diabetes, heart in cardiac management, salt is kidney. So everywhere the discussion is about the same topic. That's why we are going to discuss about SGLT2 inhibitors. Often in slides you might see the example of Dapagliflozine, but overall we can consider it as a class including Empagliflozine. So the first thing I want to begin is regarding the pathophysiology in the diabetes. You might feel we have started with the updates and now I am going back to pathophysiology, but it is very helpful if you understand the mechanisms involved in the pathology of diabetes. So for this I will give an analogy of a family where there is a weak father who is not able to put up his opinions in the family. So that weak father is nothing but dysfunctional beta cells which are not able to produce insulin. Then there are adamant children in the family. When someone tells some opinions, they are not ready to listen. They are totally resistant. So this is nothing but the insulin resistance, the second mechanism in diabetes pathology we can say. So this already disrupted problematic family is invaded by some masala relatives which is very common in India. So the first masala relative entering here is the overproduction of glucose by liver, again leading to hyperglycemia. Second masala relative will be gluconeogenesis by the renal system. So this is related to kidneys, adding further glucose load in the vasculature. With all this problematic scenario, obviously there will be disturbance to the mental health. So what does that indicate? There will be dysregulated appetite and satiety mechanisms in diabetes. So once we imagine this scenario, now we will be able to justify how the oral hypoglycemic agents or anti-diabetic medications will come into action. For example, to stimulate this father or the beta cells, there are numerous medications, commonly sulfonylureas, which will help as secretagogues. Similarly, GLP-1 receptor agonists will do the similar mechanism, and DPP-4 inhibitors. All these we can consider as secretagogues. In some or the other way, they are helping in the production of insulin. Coming to adamant children, how we can handle them? The only way to improve insulin resistance is through exercise and weight loss. Then, regarding the hepatic overproduction of glucose, we can utilize metformin. And for the other mechanism, where renal reabsorption can be inhibited using SGLT2 inhibitors, which is the topic of discussion today. Coming to the stability of appetite and hunger, we know that numerous lifestyle interventions as well as the newer group of medications like GLP-1 receptor agonist will act at various centers including hypothalamus for the regulation of this imbalance. So whenever you think of diabetes, always imagine this problematic home so that you will get to know using what medication we can target the pathology. Now we will begin the discussion on SGLT2 inhibitors. So primarily we told that it will act somewhere in the renal system, right? So mainly if you observe the S1 segment of proximal convoluted tubule, that is responsible for about 90% of the renal glucose reabsorption, right? So these medications will inhibit SGLT2 channels in the proximal convoluted tubule, leading to non-reabsorption of the glucose. So there will be excretion of glucose in the urine. To what extent it can impact is nearly about 280 calories will be eliminated from the body using these medications. It is almost equivalent to 45 minutes to 1 hour of moderate intensity workout. So with this primary mechanism, there starts the additional benefits. For example, as the name indicates, SGLT2, right? So it will be sodium and glucose co-transport. So along with the loss of glucose, there will be definitive loss of sodium. So with these osmotic agents, there will be drag of fluid, leading to volume loss to some extent. For example, about 300 ml to 1000 ml we can say. So definitely this sodium loss will help in the control of blood pressure as well as good for cardiac and kidney health. Whereas volume loss will be helpful in regulating BP as well as in cardiac overload states. So combining all these mechanisms, these drugs are very beneficial in case of diabetes management, kidney health, BP regulation as well as cardiovascular benefits. So now we got to know three basic mechanisms, that is glucose loss, sodium loss as well as volume loss. But if we go in depth, there are several other mechanisms through which these SGLT2 inhibitors will be impacting. That's why we call it as pleiotropic effect. For example, there will be improved arterial stiffness. So definitely this will lead to better hemodynamic improvement, which will definitely help in reduction of blood pressure. And there will be improved endothelial function, which is being observed in various trials. So this is the primary mechanisms for numerous adverse cardiovascular events. So with this mechanism, we can say it has cardiorenal benefit irrespective of the glucose excretion mechanism, we can say. Then it has been observed that it will reduce the inflammation in the body. Also, there will be sustained diuretic effect. So these are the added advantages of using SGLT2 inhibitors. I hope you have understood all the effects of SGLT2 inhibitors. So with these mechanisms, we can clearly say these medications are helpful in case of diabetes with heart disease individuals as well as diabetes plus chronic kidney disease individuals. Now the question comes, if there is no diabetes in an individual but still they are having chronic kidney disease or heart disease, so in that case can we utilize these medications? The answer is clear yes, because you have just now observed the pleiotropic effects of SGLT2 inhibitors, which will lead to reduction of inflammation as well as improvement in endothelial function and arterial stiffness. So all these mechanisms are independent of glycemic control. So definitely, if the case is a cardiac patient or chronic kidney disease, even if there is no diabetes associated, you can still utilize this medication. Coming to some of the landmark trials which everybody will be speaking in CMEs and all, which we have to know as evidence when it comes to SGLT2 inhibitors. Mainly regarding cardiac health, they have conducted DAPA-HF trial, DELIVER trial and DAPA-MI trial. So the overall outcome of all these trials we will see now. So there will be decreased cardiovascular deaths, so it has mortality benefit. There will be decreased heart failure hospitalizations when we use this medication, and there will be reduced all-cause mortality, as well as there will be improved clinical symptoms and improved quality of life. So overall, it is very much beneficial in case of cardiac health. When we see the kidney-related trials, for example, DAPA-CKD, DAPA-SALT trial, so outcome was there will be slowing of progression of the chronic kidney disease. So to some extent, we can halt the progression of the illness, and there will be lesser cardiovascular deaths, which is the commonest cause of mortality even in chronic kidney disease patients. And as seen in heart-related clinical trials, even in CKD, there will be lesser all-cause mortality when we are using SGLT2 inhibitors. But here the point to be remembered is the eGFR must be minimum 30 before considering these medications. Nowadays they are saying we can still go down till GFR of 20 ml per minute. We can use these group of medications. So after seeing the mechanisms and various evidences through numerous clinical trials, now how to prescribe these medications practically in day-to-day practice. So according to ADA 2025, in fact we can say 2026 updates, regarding which I have posted a detailed video on our channel. So how to prescribe in case of type 2 diabetes. First of all, whenever you get a case of newly detected diabetes or when you see the individual for the first time, first decide whether there are any major comorbidities. In the sense, is the patient have any high risk of cardiovascular events? We need to calculate ASCVD score as well. If you feel the individual is at high risk of cardiovascular events, for example, the ones who are having associated hypertension or family history of heart disease, dyslipidemia, overweight or obesity, or history of smoking. So in these cases, we can directly choose SGLT2 inhibitors as the first line agents. If these high risks are not there, then we can consider metformin as the starting agent and we can add on with the SGLT2 inhibitors if you find any of these risk factors associated. So overall, metformin is still the first line agent when there are no comorbidities. Suppose the individual is having heart failure, it might be either reduced EF or preserved EF, or if you see a case of CKD, don't hesitate to start SGLT2 inhibitors as the first line agent unless the eGFR is less than 30. So this point has to be remembered. Overall, we can consider SGLT2 inhibitors as the first line agents, either single or in association with metformin, especially when there is high risk of cardiovascular events. This is the overall point. And when it comes to heart failure per se, just remember in all the types of heart failures, either it may be preserved EF, mid-range EF, even in the reduced EF, we can consider SGLT2 inhibitors as class 1A recommended medication. So all the international consensus like AHA, even NICE guidelines are supporting this fact. When it comes to recommendations in relation to kidney health, again, as I mentioned, if the GFR is more than 30, we can utilize SGLT2 inhibitors as the first line agents along with lifestyle changes, dietary advice, physical activity and weight management as well as tobacco cessation. And also now the trend is they are discussing about the 4 pillars again in relation with CKD. Probably you might be knowing regarding the discussion of 4 pillars, that is GDMT in heart failure with reduced EF. Similar things are under discussion when it comes to CKD. So what are those 4 pillars? Mainly RAS inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists and the newer one, that is non-steroidal MRAs. So these are the newer agents strongly recommended in the management of CKD patients. I will have a detailed discussion on non-steroidal MRAs as well. So overall, we got to know that this is the best medication when it comes to cardio-metabolic health. How about the combination with other anti-diabetic medications that we will see now? As mentioned, Dapa plus metformin, this combination we can choose as the first line agent in various diabetic patients, especially if they have higher cardiovascular risk. So they will have synergistic action, yielding greater reduction in HbA1c and body weight. If you remember the masala relatives, that is one from the liver and another from kidney, we can target by combining these two. Similarly, when it comes to SGLT2 inhibitor along with DPP4 inhibitors, this combination is very helpful, especially if the patient is having some cardiovascular comorbidity. And these cardioprotective effects are linked to ketone bodies. Coming to insulin combination with DAPA, so this will significantly reduce the requirement of insulin dosage. And the emerging therapy, that is SGLT2 inhibitor plus non-steroidal MRAs like Finrenan. As I mentioned, this is the future cornerstone, especially in CKD management. But what is the safety profile and adverse events which we need to monitor when we think of using SGLT2 inhibitors? So there will be increased risk of mycotic infections in the urinary tract because of glycosuria. So we need to advise to maintain good perineal hygiene as well as adequate hydration. And if there is recurrent urinary tract infection, then we need to avoid this particular medication. And in some trials, it has been reported to result in nasopharyngitis, but it is not a problematic thing. As well as there will be initial fall in the GFR. So roughly about 30% of GFR will fall when we initiate the treatment, but the point to remember here is it will again normalize over a period of 6 to 8 weeks. So whenever you start, if you see a trend of fall in GFR, don't immediately shift towards stopping this medication because you have to know that it will get normalized over some period of time. And regarding ketoacidosis, there were numerous other causal factors, for example, type 1 diabetics, some other stressor events, which led to ketoacidosis, but it is not due to SGLT2 inhibitors per se. So this point has to be remembered. And regarding limb amputation, it was seen with the usage of canagliflozine, but it is not a class effect. So overall, the prescribing blueprint is like this. Any adult with type 2 diabetes mellitus, we can start with dapagliflozine 10 mg once daily dosing, which can be administered with or without food. But the contraindications are severe renal impairment, that is eGFR of less than 30, and if the individual is on dialysis. But nowadays they are saying even we can utilize this if the patient is on hemodialysis, and there are no adequate safety data regarding the usage of this medication in pregnant and nursing mothers. So overall, I can say when it comes to cardio-renal metabolic wonder pill, no doubt that SGLT2 inhibitors will stand in the first line. So according to our title, Sweetheart Salt Story, it has supreme efficacy in the type 2 diabetes management and class 1A recommendation in all range of heart failure patients, as well as a true wonder pill in the slowing of CKD progression. So we used this closing statement when we had seminar on this topic. So to make a Sweetheart Light, use Dapalite because that was the brand name which we were discussing about. But in general, we can say the class of SGLT2 inhibitors. Thank you so much. Why I discussed this particular topic is this is in the trend, and any CME you attend, this will be the commonest topic discussed. So I want you to enjoy the CME, especially the food and drinks there, because you are already very well versed with this particular topic after watching this video. Thank you so much, and do not forget to subscribe to our channel for more such updates and discussions in medicine.